Okay, welcome everyone. Welcome to the Society of Thoracic Surgeons Intermacs User Group webinar. It's Wednesday, October 27th. It's a great day here. I hear it's not a great day in Boston. I'm sorry. It's a beautiful fall day here. So, and thank you, Carol. Thank you for the wonderful music, festive, get us in the Halloween spirit. So again, today's webinar, we are going to review, I'm going to provide an overview of the updated adverse events. These are actually slides that you can find at AQO, but also we'll take any questions also at the end after the review. So today I want to welcome our UAB team, and I'll welcome all of them in a few minutes. So STS updates, I want to thank everyone that participated in AQO 2021. It was a success. I believe we had over 1,400 participants, which was amazing. Today, we are going, like I said, we're going to go over have an overview of the new adverse events, which will go live in the database this Friday. The next slide, I do want to let everyone know that we will have another webinar probably I'll give it a couple of weeks after the AEs go live. So if you have people, once you see them and start entering data, you'll probably have more questions. But the data collection forms should be posted, I believe. Are you going to post those Thursday, Chase, or Friday?
Those will be posted on Friday.
Okay, thank you. So the updated AE data collection forms will be posted on the Intermacs under the appendices on Friday. So I want to introduce the Intermacs Data Warehouse team. We have Dr. Ron Cantor, who's listening today. He's the Director of Reporting. Dr. Radaruju, he's the Director of our Programming, who's done him and his team, which includes Chase on the call today, and John works with him. They've all been involved in this, getting the data fields updated for the new adverse events and other exciting features such as the dashboard and the outcome and analytical tool update. We have Patricia Potter, who's the quality and informatics nurse at the Intermacs Data Warehouse. Mrs. Jeannie Ann Love, who's the patient management director at the Intermacs Data Warehouse. John Pennington, who's the senior data manager, who helps package cleans up the data and helps with the programming and version upgrades. And Chase Linderman, who does a lot of work behind the scenes, responsible for the web page and the data collection forms and programming and a lot of the new features and the adverse events were his ideas. So thank you, UAB. Just want to go through the contact information. You can contact myself with questions and answers after the webinar, or Patricia Potter, or if you have any database operational questions, you can send them to the Intermacs FAQ email. We also have some resources. We've got the STS webpage, our Intermacs and PDMacs webpage, which is, you'll find all things Intermacs and PDMacs, from the user's guide to how to do the trail making test, and the educational tools are found there also. You have the email for the anything regarding the reports, reporting questions, how to upload them, your password and login for the reports. If you need any of that, then you can use that email address to contact Maceo. We also have a participant contact form and a DQ report validation form, which people should be completing if you have any updates to your data quality reports. Our next webinar is going to be tomorrow, October 28th. It's our dashboard analytics webinar. If many of you that joined last week, just to let you know, that was the scheduled topic, but we had actually the power went out at the building that where the Intermacs group works. So we couldn't do that, but thanks to Ron Cantor, who stepped in and did a review of the outcome analytic tool. So tomorrow will be the dashboard analytics overview, and it's a wonderful presentation. I encourage you, it's a great tool. I think everyone's gonna love it. I encourage everyone to attend the webinar before they start using it. And then we'll just do some housekeeping. This is an open discussion. I'm going to review the updated adverse events. For any questions, please use the Q&A function. We will answer as many questions as possible. We encourage your feedback because we want to hear from you to make Intermacs better. So I'll start again. It's an updated adverse events overview. So I'm sure many of you've heard the major adverse events for Intermacs are major infection, major bleeding, neurological dysfunction, and device malfunction, device failure. There's also updates to hemolysis, right heart failure, and renal dysfunction. For the major infection on that form, you're going to notice that now you are coding either their MCS related infections or their non-MCS related infections. So MCS related obviously would be something with a device, like if a lead site infection. Non-MCS related would be like your urinary tract infection, your any localized non-MCS device infection. Could be pneumonia also. Major bleeding, it's been updated. So now the bleeding AE has types, and we have 1 through 5. Type 1 is bleeding that is not actionable and does not cause the patient to seek unscheduled performance of studies, hospitalization, or treatment by a healthcare professional. So like a common nosebleed. And I know we can get into the nosebleeds that just go on, but this would just be your easy, everyday, simple nosebleed that the patient could kind of take care of their own. Type 2 is an overt actionable sign of hemorrhage, like more bleeding than would be expected for a clinical circumstance, including bleeding found by imaging alone that does not fit the criteria for types 2, 3, or 4, or 5, but does meet at least one of the following criteria: requiring non-surgical medical intervention by a healthcare professional, leading to hospitalization or increased level of care, or prompting evaluation. So type 2 would be yes, they need to go, they either they have to go to the ER or they have to go to the doctor's office, and there's some kind of action has to be implemented to stop the bleeding. Our major bleeding type 3, we have 3A and 3B. 3A is overt bleeding accompanied by a hemoglobin drop of 3 to less than 5, and the hemoglobin drop must be related to the bleeding event. 3B is overt bleeding accompanied by hemoglobin drop of 5 or greater, and the hemoglobin drop must be related to the bleeding event, such as examples would be cardiac tamponade, bleeding requiring surgical intervention for control, excluding dental, nasal, skin, and surgery for hemorrhoids. Or could include bleeding, any bleeds that are requiring IV vasoactive agents. So basically, if there's an action, and then if they receive any IV vasoactive agents to help with the bleed. Our next, we'll review type 4. Our major bleeding type 4 is VAD implanted related bleeding. So reoperation after the closure of incision or incisions used to implant the VAD to control the bleeding. And then if the patient's greater than 50 kilograms, if greater than 4 units of packed red blood cells within any 48 hours during the first 7 days post-implant. So that's important. if they have received greater than 4 units of packed red blood cells within any 48 hours during the first 7 days post-implant. So it's that first 7 days if they receive greater than 4 units, and it's related to the VAD implant. Or if the chest tube has output greater than 2 liters within 24 hours. Our next we'll review is type 5, so fatal bleeding. We have 5A and 5B. 5A is probable fatal bleeding, no autopsy or imaging confirmation, but you're pretty sure, pretty clinically suspicious about it. And then 5B is the definite fatal bleeding with confirmation. So basically type 5 is fatal bleeding, 5A is, it's not confirmed, but everyone suspects that's what it is. And then 5B is when you have definite fatal bleeding and confirmation. Okay, our next AE we'll review is neurological dysfunction. This has also been broken down into types. And I think everyone, they're a little more clear cut since we have the types. We have types 1 through 3 for neurological dysfunction. Type 1 is overt CNS injury, acutely symptomatic brain or spinal cord injury. So your strokes, ischemic stroke with hemorrhage. Type 2's covert CNS injury, acutely asymptomatic brain or spinal cord injury detected by neuroimaging. And then your type 3's your neurological dysfunction. It's acutely symptomatic without CNS injury. So your TIA or delirium, those would be examples of type 3. Our next adverse event will review device malfunction. We have major device malfunction and minor device malfunction. So, for the minor device malfunction, I know we're pretty familiar with these. An example of minor device malfunction, just a note is, because we receive this question frequently, if you replacement of the external controller, if it's done in an inpatient setting for logistical reasons in a stable patient, should be considered a minor device malfunction rather than major. So if the patient's just already at the hospital or the doctor's office and you're having to replace the external controller, or if they're in another inpatient setting because they had another appointment, and they decided to change that out, then that would be considered a minor device malfunction rather than major, even though they're in an inpatient setting. So hemolysis, now we're going to get to our additional adverse events. Hemolysis is now an entered event. So I know we went through, I believe it was 7 years, and John maybe can correct me, or Rama if I've misspoken, but 7 years we had hemolysis as a triggered event, where the database had an algorithm programmed, and depending on what you entered in the data fields, certain data fields, it would trigger a hemolysis event and label that patient that they had a hemolysis event. Well, now sites, you're allowed to enter your own, if you believe it is a hemolysis event, now sites enter the events. We have major hemolysis and minor hemolysis still. For the major hemolysis, it's a plasma-free hemoglobin value greater than 20 milligrams per deciliters, or a serum LDH level greater than 2.5 times the upper limits of the normal range at the implanting site, occurring after the first 72 hours post-implant. So for it to be major, it's after the first 72 hours post-implant, and it has associated clinical symptoms and findings of hemolysis or pump malfunction. So that definition didn't really change that really. And for minor hemolysis, Minor hemolysis is a plasma-free hemoglobin value greater than 20 milligrams per deciliter, or a serum LDH level greater than two and a half times the upper limits of the normal range at the implanting site, but this is still occurring after the first 72 hours. But for it to be minor, they do not have any clinical symptoms or findings of hemolysis or pump malfunction. So the major hemolysis, it's still after the first 72 hours post-implant, but they have clinical symptoms and findings of hemolysis or pump malfunction. And those will be listed on the form. You can check the clinical symptoms or the findings. And then the minor hemolysis, again, it's after the first 72 hours, just like major, but they do not have clinical symptoms or findings of hemolysis or pump malfunction. Next, we're going to get to the right heart failure adverse event. Again, the right heart failure adverse event, I know for years many sites wanted to be able to enter this adverse event as it occurred. And so now you're going to be able to. It also is no longer a triggered event. Sites will enter right heart failure events as they occur. We have early right heart failure, early acute right heart failure, early post-implant right heart failure, and late right heart failure. So let's review this early acute right heart failure. The early acute right heart failure is need for implantation of a temporary or durable RVAD, and even if they will include ECMO, even though Intermacs does not collect details on ECMO, concomitant with LVAD implantation. So basically, if the patient received a BiVAD, or if it was they RVAD implanted before the patient leaves the OR. So for the early acute right heart failure, the patient receives a BiVAD, and that is what they will call during the implanting procedure. So that will take care of the early acute right heart failure. And next we'll look at the early post-implant right heart failure. This is need for the implantation of a temporary or durable RVAD, including ECMO, within 30 days following the LVAD implant. So within 30 days following the LVAD implant, if they receive a temporary or durable RVAD, including ECMO. Or if they also have failure to wean from inotropic or vasopressor support or inhaled nitric oxide within 14 days following the LVAD implant, or having to initiate support within 30 days. So if they're receiving any of these inotropic or vasopressor support or the inhaled nitric oxide within 14 days following the LVAD, or if they do have to even begin these within 30 days, then it would be early post-implant right heart failure. And they must have 2 clinical findings and 1 manifestation from the criteria listed on the right heart failure form. In that, those will be listed. And it's the JVP, it's the elevated CVP. So it's the same variables, the options that you had on the previous when we had the right heart failure on the follow-up forms. So for late right heart failure, then it's going to be greater than 30 days. If you have an RVAD implantation, including ECMO, greater than 30 days after an LVAD implant. This may occur within the index hospitalization for LVAD implant or during subsequent rehospitalization for any diagnosis which results in the need for a temporary or permanent right-sided mechanical assist devices. So basically, if they get the RVAD and it's greater than 30 days from the LVAD implant, then that would be late right heart failure. Then we have hospitalization that occurs greater than 30 days post-implant, which requires the IV diuretics or inotropic support for at least 72 hours and is associated with 2 clinical findings and 1 manifestation. And again, the clinical findings and manifestations will be listed on the form, and I'm hoping to be able to show you those forms. So again, the late heart failure, it's greater than 30 days. And even if they receive an RVAD, and it's hospitalization that occurs greater than 30 days, again, and the patient requires IV diuretics or inotropic support for at least 72 hours and is associated with at least 2 of the clinical findings and 1 of the manifestations, which will be listed, you'll be listed for you in the database. So now we're going to review those late right heart failure clinical findings. Must have 2 of the following clinical findings, 2 of these. So ascites, the functional limiting peripheral edema, so greater than 2 plus, elevated estimated JVP at least halfway up the neck in an upright patient, or your elevated CVP, which elevated is considered greater than 16. So you must have 2 of these clinical findings and 1 manifestation. And the manifestations are renal serum creatinine greater than 2 above baseline, liver injury with an elevation of at least 2 times the upper limit of normal of their AST, ALT, or total bili is greater than 2 point. Their pump flow reductions greater than 30% from previous baseline in the absence of tamponade. Your SVO2 is less than 50%. Cardiac index is less than 2.2 liters, or your elevated lactate greater than 3.0. So remember, for these right heart failure manifestations, you have to have 2 clinical findings and 1 manifestation. And next, we'll review our renal dysfunction. So our renal dysfunction, we have, this is its own form now, so it's a separate form. You'll see it on Friday. We have acute versus chronic now. The acute has 3 stages, and they vary in your serum creatinine levels and your urine output, but they're very specific. Stage 3 for acute is renal replacement therapy, and that includes dialysis or ultrafiltration. And then for our chronic is the increase in serum creatinine of 2 or greater above baseline or requirement for renal replacement, either of which is sustained for at least 90 days. So for it to be chronic, it has to be sustained for at least 90 days. The increase in serum creatinine or the requirement for renal replacement to be considered chronic. So one thing you will notice at the end, in addition to the at the bottom, excuse me, of the adverse event forms, is the association classification. So we have patient-related, which would be non-adherence to medical therapy. So if the patient forgot his medicine for a day or 2 or took the wrong dose. Management-related would be the medication management or medical treatment-related issues. So patient-related would be non-adherence to medical therapy. So if they just were very non-compliant. Management related would be, was the dose too low? Was their heparin too low? And so they ended up having a device malfunction or a hemolysis event. Device related would be the device issues resulting in this adverse event. And usually for those, you can work with your team to find out which one would be the association classification. So that is, I am done with the slides for today, and thank you. I'm going to go through take you through QA now. I'm going to stop sharing my screen for a second and get to QA. And so I hope that, again, the slides for these webinars will be posted. So you will be able to review these slides. They'll probably be posted by the end of the week, I would hope. And so we will go ahead. I apologize for that delay. And can everyone see my screen that has the dashboard on it? Someone send me a...
Yes, we can see it.
Okay, great. Thank you. Appreciate it. So this is actually when you log into the database, we will go to, we're going to use Hospital X, which is actually, it's a de-identified, so no patient identifiers will be shared. These are all de-identified patients. And it's a random sampling, so they're not even real. But we will go ahead and I want to show you some of the forms and what they will look like. Maybe. There we go. So you will still just create an event for these adverse events. You'll click on create event. It's going to still take you to the AE label. You'll choose the date, and we'll just choose today. And then you have our label describing this event, and I'm just going to say bleeding. You can be as detailed or succinct as you would like. Hit validate and save. Then it's going to take you to the AE. You'll see here on the left your AE listed, including rehospitalization, the explant form, and the death form and pump change form. But you'll notice we have a hemolysis form, right heart failure form, and renal dysfunction. So I think first, let's go through the infection. We'll go through that. If there was a major infection, you would say yes. And then here's where it asks you, is it MCS related or non-MCS? If we click non-MCS related, then you can select all that apply. What is new is this show more. So you can click on show more, and it will provide in-depth detail. You have your data onset. Here's the association classification. And again, those are on all forms. One thing also to review is for this type of infection, the infection type, if you do choose bacterial, now it is going to ask you if it's gram positive or gram negative. And if you choose one of those, you will have a few genus and species to specify. And it will do the same for gram negative. So, but otherwise the form really does look the same. It's a really nice job in how they show more details. So we'll go back to the, we'll go to the major bleeding form. If you select yes, here are the types that I had gone over and what I had discussed. If you, let's go to type 4, which is VAD related bleeding. You'll see if you choose that, and then you have your options. You can select all that apply, and then the rest is the same as far as the source, cause, and location. So I kind of just want to quickly take you through some of the new forms. Next, we'll go to neurological dysfunction, and remember this is types 1 through 3. again, with your show more, your overt, covert, and then your neurological dysfunction, acutely symptomatic without CNS injury. And that's where you would include like seizures. And so, and then everything else is the same. For the device malfunction, failure, or pump thrombus form, if you select yes to was there a device malfunction, then it's going to, right off the bat, ask you if it's major or minor. Again, when you click major, then you would click one of these options. You can check all that apply, the date. We still have our great handy text box, which is wonderful because you can give us all the details of how the device, the description of the malfunction, how it occurred, what component was involved, and the outcome and any interventions. And then if there was a device thrombus, and you select yes, it's suspected or confirmed. If we do suspected, because we haven't confirmed it, then again, you'll just check all your signs and symptoms and all the interventions. And I believe this is check all that apply, correct? Yes, it is. So you can check all of these, and then you have your date and the association classification. So we will look at the hemolysis, because now you may enter it on your own. You still have a reminder for it on the follow-up forms. Well, just the question is, did the patient experience a hemolysis event? And then a pop-up to remind you to enter the hemolysis event if you select yes. The minor and the major, and remember the major, it will explain everything that I had discussed, and then you can choose your options, and then the association, and then where you enter your plasma-free hemoglobin or your LDH, again with your hematocrit or your hemoglobin, and then the highest total bilirubin. And then your minor. Okay. That would be the hemolysis form, and then the right heart failure form. If the patient did have a right heart failure event, we have those three options. We've got the little early post-implant right heart failure. And you can show more in all tests. This one's not the early acute. So this would be for the early post-implant. And then you have your late right heart failure, and then your options right here to check. And our association classification. And then we have our renal dysfunction. On that form, if you, yes, we have the acute and the chronic. Here's your acute with your stages 1, 2, and 3. And like I said, it varied between the creatinine levels and the urine output. And so again, you can click on this show more and it will give you all the details. So that is what the forms will look like when you're able to review them on Friday. I believe you'll be able to look at them. They'll probably you'll be able to look at them in the morning. I think, are they going to launch in the morning, Rama?
So currently it will be Friday evening. So
okay. So it'll probably be in the morning or mid-morning when you log on, you'll be able to see those new forms. So now I just want to thank everyone for joining. But before we leave today, let's go ahead and answer some Q&A.
Catherine, this is Trisha. I can help you answer some of these if you'd like.
Okay, sure.
Okay, so our first question is, so if a patient calls with a nosebleed type 1 and stays home, it needs to be entered into Intermacs. We'll miss many of these episodes if patients do not report. So the type 1 is non-actionable bleeds. They didn't need to seek any medical attention. They were able to manage it on their own at home. Yes, they should be entered in as a type 1 if there was a bleeding episode. Hopefully at follow-up at clinic visits, it will get discussed there and will be documented in those clinic notes, and it can be entered in at that time.
Yeah, thanks, Patricia.
Yeah. And then the next question from Chelsea, what about controller changed in an outpatient setting? So on the device malfunction form, as long as it's not routine maintenance, changing out a controller, it can be captured on the form. There is an option on there to select controller and then what components were malfunctioning. And there is an option on there for the location of the patient, and you can select out of hospital for that.
Yeah. Thanks, Patricia.
Yep. And then our next question, what if a patient has a drop in hemoglobin and receives 1 or 2 units of red blood cell transfusion every 2 to 3 days in the course of 4 weeks, post 7 days from implant? The patient has received 12 units of red blood cells. How do you code? So if I'm understanding the question correctly, this is after the 7-day mark, post-op day 7. So correct me if I'm wrong, Catherine, but this would not be considered VAD implantation bleeding anymore. And if they were requiring transfusions after that, it would need to meet the criteria of type 2, 3A, 3B bleeding. Is that correct?
Right, that's correct.
Yeah, so it would no longer be considered VAD implantation bleeding at that time. So as long as it meets the definition of one of the other 2 types, or of course, fatal bleeding, but not type 4 for the implantation bleeding.
Great, thanks, Patricia. And I know just to add, I know we have not had an adverse event update, and I believe, and again, John Rama, let me know if I've misspoken, but I think it's probably been 7 years.
That was the last major update. Yes, ma'am.
Yeah, so it's been a long time. I know it's going to take time, and we're going to have questions, and there's going to be times when I'm going to have to ask the surgeon leaders. So yeah, so it's all going to take us time to get used to these. And Bonnie, I can take that one, Patricia. Regarding
sure.
hemolysis, what are the clinical symptoms to use to identify major hemolysis? So I think you might have sent this in before I went over that. So hopefully you saw it. If you didn't, I can email them. I made a note to email them to you.
I think I can take this one, Catherine.
Okay.
What should we code if CVP is typically running 12 or less and 1 off of 18? So for the right heart failure definition, I believe that it needs for the, for the clinical findings, it needs to be a CVP greater than or equal to 16. Is that correct, Catherine?
Yes, that is correct.
Yeah, so it needs to be, so the 18, but it needs to be greater than or equal to 16 for the CVP.
Yeah, thank you.
And then the next question, with the new version and adverse events that used to auto-generate, it seems like this could take a significant longer time to abstract. So the right heart failure and the hemolysis are no longer triggered events that just populate after we put our lab values in. You do have to enter them. The forms aren't too lengthy. I think there will just be a little bit of a learning curve with entering them, but both the right heart failure and the hemolysis, they're not lengthy.
Thanks, Patricia. I'll take this one from Dia. When will the quarterly reports reflect these new definitions? And how will the reports bridge the old new definitions over the recent year report? John, I don't know if you want to take that. I know Ryan said he may be listening, but we might have lost him at this point.
Yeah, I don't want to overstep when I'm talking about what's going to be in the next report. So I can see if I can grab him, or I can just ask him if he can type something up.
Okay, that'd be great. Do you want to take this one?
Yeah, I can take it. What if a patient has signs of right heart failure per MD documentation post-implant, which adjusting of medications were performed anytime during post-op day 1 to post-op day 14? Do not lead to temporary device or weaning failure of inotropic or vasopressor support, since it was not attempted at that time. So if you're talking about the time period post-op day 1 to post-op day 14, that would be early right heart failure. So you would select early right heart failure, and you have to select one of the categories. And the 3 categories are having a temporary device, including ECMO or durable RVAD, temporary or durable RVAD, or failing to wean from inotropic or vasopressor support. So I feel like this may be a gray area if it's documented that it's right heart failure, but they haven't been on RV support in the form of a vasopressor or a temporary device.
Yeah, this might be one, honestly, to send the scenario. If you want to send more details to one of us, and we can forward to the surgeon leaders, because this does kind of look like because it doesn't have the temporary VAD or ECMO, and they didn't really wean. But there's also other but if the presence, I think what you may be saying is, but if they have 2 of those clinical findings in one of the manifestations,
but didn't fit one of the categories.
Right. So that's definitely something. If this is a scenario, if you want to send Patricia or I more details, and we can forward it on to Dr. Pagani and let him review it.
Thanks, Catherine. Okay, so our next question from Tim: can we be asked about AE within 1 week or 1 month fields? It feels like we have to go and find that, and it can be missed if it's soon after implant. I'm not sure I'm understanding the question correctly. AEs can be entered at any time after implant.
Yeah, are you just wanting like a reminder? Maybe he's just wanting a reminder. I think we used to have that back in the day before the version 4.0. We had we listed the AEs and said if the patient had experienced one of these, then please enter it. I think that's what you're meaning, Tim. If it is, please let us know. And we can definitely look into adding like a reminder to enter the events, just a text field.
Okay, and our next question for the hemolysis form, would I be right using the same practices performed when submitting the patient's follow-up forms, reviewing labs since last visit, and finding peak values for the hemolysis zone? Yeah, that's exactly right. So you'll be looking at your peak plasma-free hemoglobin and your peak serum LDH, and just looking at those clinical findings for the conditions: hemoglobinuria, anemia, hyperbilirubinemia. But yeah, that's exactly right. Just looking at the labs and the patient's clinical findings.
Yeah, thank you.
I have a response from Ryan D's question, if I can.
Sure.
Yeah, so we've worked pretty diligently, I think, to make sure that all the adverse event information on the new forms maps over to the old forms. I met with Ron previously. So far, we're pretty sure that the exhibits that are included in the reports are all mapped one-to-one, which means the old data maps over to the new form successfully. He's saying right now, though, he's going to reserve saying everything will be there. Some of the more complicated exhibits may have to be turned off for a quarter, but we're expecting that with the data that we pull down in November, these will be in your December reports.
Thanks, John. Thanks for getting that answer. Rebecca, she's asking, did I miss anoxic brain injury in the neurodysfunction on that form? No, it is in there, and I'm trying to look for.
I think it's 1E.
Yeah, it looks.
Type 1E, symptomatic. Yeah.
Yes, it is. Thanks. And do you want to take this one, Patricia?
Oh, sorry, I was on mute. Yep. Will the follow-up form with the zone section change since we are entering right heart failure and hemolysis events? Chase and John, I believe we left the questions on the forms, correct? It's just not going to trigger the event.
No,
But
there's
the
just sorry.
lab questions are still on there.
No, there's just the yes, no now. So on the follow-up forms, there'll be the question for, was there an event? And then we prompt the users to go in and complete an adverse event form.
Great.
Yeah.
Thanks, John.
Yeah, so the actual questions, Patricia, like what did they used to enter the data? So those are all moved to the AE form. So they'll be no longer, those questions will not be there anymore. It's just the one yes, no question and then a reminder.
But to piggyback too off of what I mentioned for the reporting, that goes into the mapping discussions we've had. We'll take all those labs, all that information you provided previously in those zones, and we'll populate adverse event forms for you for those historic, what used to be conditions that will now be events.
Great, thanks, John. Nancy's asking, the CV question was asked about was a one-off of 18. Okay, a one-off of 18. So if they didn't have any other signs and symptoms, then you wouldn't, if they didn't have any other the clinical symptoms or manifestations and it was a one-off, then you wouldn't enter that for the right heart failure. And then Sue Ellen, will there be written AE definitions that we can refer to and also share with investigators? Yes, and I believe Jeannie Ann and Chase, these will be, the written definitions will be posted either probably Thursday afternoon or Friday.
Yeah, we'll have them posted by Friday morning.
Okay, great. Thank you.
Okay. Thanks for answering. So the random CVP of 18 will trigger a right heart event, providing the other criteria are met. My fear is overcoding if the patient has turned and is coughing, etc. No. So nothing is going to trigger hemolysis or right heart failure events anymore. They're, entered by the users. And so no. So the random CVP over 18 does not need to be entered if the patient isn't having clinical signs and symptoms.
Right. So there's the right heart failure and hemolysis are not triggered events beginning Friday, October 29th. sites enter those events as they occur.
Should we still enter all rehospitalizations in addition to the new AEs? Yes. So we still do have the rehosp form, and any rehospitalizations related to the VAD or not related to the VAD over 24 hours should be entered.
Great, thank you.
And then this next one, we'll send a more detailed scenario. I think that was in regards to right heart failure not being on RV support.
Right.
And then the next question, if the patient has an ECMO and the oxygenator is removed, therefore the ECMO becomes a temporary RVAD, do you record this in the right heart failure section and create a new pre-implant and implant form? Yes. So when the ECMO becomes a temporary RVAD, that is added in to the patient summary. And this would also be you can either enter the right heart failure AE at that time, or once the patient meets a right heart failure definition, if that was the time they went on to ECMO.
Yeah, thanks, Patricia. And then Tim responded back, yes, that's correct. So to have the reminders at the 1 week and 1 month follow-up forms. And yes, I have a meeting with the programmers tomorrow, so we can talk about, Tim, what we can add just to remind the sites to enter the events at those early forms.
Do both an add device form and an adverse event form for an RVAD. So to add the RVAD in, yes, you would click on add new device. If you are entering right heart failure, that would be yes, under the adverse events forms for right heart failure, if you need to enter that one as well. But to add the RVAD, you click add new device.
So that is all the questions we have for now. Oh, there might be one more that popped in. We'll get it. We're almost done with the time.
Will these questions be added to the FAQs? Yeah, that'd be a really good idea. So I update the FAQs quarterly, so I'll do the next one the end of December. Catherine, can we save these questions and I can add them in?
Yes.
Go
ahead,
ahead. Or,
Carol. This is Carol. Yep. Actually, I can run a report and I'll send it over to you.
Okay, thank you. Yeah, great idea. And I'll add these into the FAQs.
Yeah, thanks, Carol. Appreciate that.
Yeah, of course.
So it looks like that is all for today. I want to thank everyone that joined today. I really want to send a shout out and a big thank you to Carol and those that joined from the STS National Database. Carol's the senior manager for the databases, and Leanne Jones, who's the lead for general thoracic and the congenital. And if Addie's on, thank you, and Sydney and Donna, thank you everyone for listening today. And if you have any more questions after the webinar, you can send an email to Patricia or I. And again, don't forget, tomorrow we have a the dashboard webinar. Tomorrow's the dashboard webinar. So at 2 p.m. Central Time, 3 p.m. Eastern. So I hope to see everyone again tomorrow. And everyone have a good day. Thank you.
Great job, Catherine and UAB team. Thank you. Bye all.
Thank you, UAB.